Okay, so Dr. Vickrey is our next Hall of Famer. I've known Dr. Vickrey ever since I joined the faculty at UCLA. As I mentioned, she was my faculty mentor for several years, and I benefited tremendously from her wisdom. Speaking of leaders in academic medicine, Dr. Vickrey is a professor and system chair in neurology and the Goldschmidt Professor of Neurology at the Icahn School of Medicine at Mount Sinai. And also one of the leaders of the American Family Clinical Neuroscience Institute. Things that are noteworthy, again, amongst many, many accomplishments. I noted this for Dr. Morgenstern as well. Barbara was the vice chair of the NINDS Advisory Panel on Health Disparities Research. And again, I was a member then. Again, I gleaned a lot of wisdom from both Barbara and Louis back then. And then Barbara is the past president of the American Neurological Association, our oldest and senior academic society for 2 years, 2016 to 2017. And Barbara is an elected member of the National Academy of Medicine. Barbara's done a lot of great work, and this, transcends not just stroke, but also dementia and epilepsy, has done some really pivotal trials, really trying to test the efficacy of chronic care-based models to try and improve outcomes for stroke and TIA patients, has also led or been a senior investigator on work to institute collaborative care management to address disparities in dementia care quality between caregivers who have high versus low educational attainment, and has collaborated on so many different consensus reports to really address issues of disparities, again, in the area of epilepsy as well. So Barbara transcends all of the different disciplines, and we are fortunate to have her present on From Discovery Science to Policy for Dementia Care, Driving Share for Population Health Improvement and Equity. Welcome.
So thank you so much. Likewise, move the mouse. Oh, can I get it? It's good enough. Close enough. I'll echo, it's a real honor to be here. I've been learning a lot today. I really appreciate speakers, the question and answer, and hearing what folks had to ask about the different projects. I wanted to circle back to your comment earlier, Bruce, about you're remembering this advice about master's degree training, and I was thinking some things are a full circle, right? So one of the faculty from Sinai, Dr. Estefana Isaac, is a Transcend Scholar. She's getting her hood tomorrow for graduation. And she has told me what a great experience, how much she's learned, and we can see that in the work that she's doing in her research as she's starting out. So I thank you and the collaborators and team that you put together for the society here and also for these programs that are so important. All right, and so thank you for an opportunity to talk here. Let me make sure whoops. There we go. So I thought I'd start with some takeaways. Oops, looks like we may have a little formatting funny things, so we'll just take that in stride. So, excuse me, one of the takeaways is thinking back about my own career. The goal was to generate evidence for policymakers. Earlier today, we heard some people asking questions about, where does this go? What is your ultimate goal? And in the particular case of chronic care for neurologic conditions, it was evident early on that the way we pay for healthcare in the US is set up for acute care, for urgent things, but we pay for chronic care in a way that doesn't incentivize the kinds of care models that produce the best outcomes. So I wanted to generate evidence that was going to be able to inform policies. We didn't caucus on this, but Louis and I had a similar message. Programs or interventions that can improve care quality can both improve overall quality of care and get health equity. And in fact, as you heard from various talks today, that there's room for improvement for everybody on many of these outcomes. And so interventions that aim to do both are definitely feasible, and I'm going to give you an example of that today. And I also wanted to bring in how important implementation science tools and concepts are for intervention research. When I started, there was no field of implementation science. There was no term really for that, but a lot has changed. And the goal here is to bring in changes that result in improvement. And I called them re-engineered care models. And I guess we've had some discussion about engineering as well. So this is the big picture, right? Our society has made a big investment in causal mechanistic preclinical research with the goal of, can we produce safe, potentially effective therapies by translating these into clinical trials? And under ideal conditions, do those trials show that there's benefit? But then there's a second bottleneck stage here of translating that clinical trial evidence and making it scalable so it's more broadly disseminated and still effective. And that's really the ultimate goal of why we make investments in research, it's to generate that knowledge. But the reality is that that last step doesn't always happen. In fact, in the past, there was a denial you even needed research in that second step, but hopefully we're past that now. And in some work by Everett Rogers, this is a wonderful book. It's an older edition now, but he was a communications professor at the University of New Mexico who started looking across all kinds of fields and found principles about how new, like innovations, which could be new therapies, could be new healthcare models, how are they diffused? And they generally followed certain kind of curve. It's the S-shaped diffusion curve. And you can see here the y-axis is the percent of adopters, and then there's time. And you can see here that there's some examples of what this curve looks like for slowly adopted innovations and for faster ones. And then there's a curve where we don't completely diffuse that innovation across 100% of the population, and that's incomplete diffusion. And that's inequity because you're usually going to find it's not a randomly assigned incomplete diffusion, but there's certain populations. And here's an example, one of many, unfortunately, but a study some years ago on, they looked at a large sample of death certificates for men with muscular dystrophy, and they looked at the age of death, and they looked at it over a 20-year span. And among white men, the age at death rose, they were living longer. And among Black men, the age of death over that 20-year period did not change, it was flat. And so this would be an example of incomplete diffusion because over that period of time, there were a number of things that were done to support the kinds of complications of cardiac involvement from muscular dystrophy. And it appeared that that was becoming more accessible and diffused more among white men than Black men in the population. And we've had some talks about stroke, and so everybody here is far more expert at this than me, but I thought this was another example of this phenomenon of slow diffusion. Younger people can't believe it, but back when I trained, if you got called about a stroke admission, you could give some recommendations that I'll see them in the morning. But that's, that obviously radically changed when acute treatments that you had to give within a short amount of time there was proven efficacy. But I remember hearing some of the leaders that helped sponsor this said, we don't understand why it took so long after that trial, this big trial was published, to have this treatment more widely diffused. And when you think about it, when you went from when there was one doctor and a stroke patient to a stroke patient knows to come into the ED quickly, they know to recognize those symptoms, they know to come in. a clock is started, there have to be pharmacy, there has to be nurses, there have to be a stroke doc, an ED doc, there has to be radiology. There's a whole group of individuals that have to have a very coordinated, rapid response in order to give this drug. That was a dramatic change. And none of those people or their activities were paid for under healthcare, right? So what happened was, no surprise, very slow diffusion. The pivotal trial is 96. By 2005, maybe 2 to 6% of stroke patients got TPA. By 2017, over 2 decades after approval, it was in the 10 to 15% range. And so there was substantial missed avoidable morbidity on a population basis because of this. So, and there's a whole literature you could, and people have dissected on why this occurs, but these are, you know, real world examples. So we were very interested in chronic care, moving to that setting. And a lot of what neurologists do, and a lot of neurological care, a lot of brain health, is chronic conditions. The traditional doctor visit-based payment really works badly. That's been known for 30 years. And there have been models developed to say we really should redesign the way we deliver this care delivery. And we know that it's got to then be translated into changes in the way we pay for care. But we have to, somebody said this, I think somebody said this earlier, you have to have the evidence, because nobody will invest in or make a policy change usually in this kind of setting without evidence that you're proposing something that would be definitely better. And this is a long diffusion arc. I call it a 25-year journey. It's partnered research across health systems and the community, very strongly reliant on implementation science. Again, the design of these types of interventions should raise care quality for everybody and eliminate inequities. That would be the goal. And I'm going to give you an example of this for educational attainment. It also has to involve, for that last piece of translating the evidence into policy change, a strong advocacy community, and where we can partner with those advocacy communities or look for willing partners is incredibly important. And the research obligations, I would say, our roles don't end. We may not be the primary advocate, but the advocacy groups definitely need our involvement. So I'm going to walk through the example of dementia care delivery. We knew way back that if you provided a really minimal amount of respite support and education for caregivers, you could delay nursing home placement, which translates across a population into enormous cost savings. But we did some survey work and discovered that fewer than 20% of people with established dementia were their caregivers provided even some of the services they needed in terms of respite care, support groups, or access to organizations that provided those. So big evidence practice gap. We also knew that there was a lot of evidence that you shouldn't start out with a behavior problem by treating with medication, and yet surveys at the time showed more than half of docs would start with medication as first-line management, and only 20% would choose a psychosocial approach. Again, though, there's a big gap here, because if you think about it, that kind of training of caregivers is not paid for in a medical setting, and there weren't, really connections to the community. So the usual care for dementia was pretty fragmented. Patients usually had a doctor, it's a solid line, but patients getting connected to services in the community was spotty. There was literally no crosstalk between healthcare systems and community agencies. And so this lack of care coordination was not the only factor, but it's a good example of where the model for paying for care doesn't align with how you get the services that produce better outcomes. So you can imagine busy doctors' offices that we can't stop. We don't even have the skill set to do these things. So when you think about it, I have a case here. This is a conglomerate of real life cases, an elderly man with Alzheimer's and a comorbid heart failure, can't remember to take his meds, resists when his wife tries to remind him. He's starting to have hallucinations. His wife is really stressed, doesn't really know when she should call the doctor, and can't afford help, and was told, well, you can call this agency, but lost the piece of paper. And so a typical outcome would be she gives up trying to give him his meds because he's resistant. He's hospitalized a couple of times for heart failure. He wandered, went to a local ER, not found for a day. Caregiver got depressed. Daughter had to leave work. Patient eventually goes to a nursing home and is rehospitalized. I mean, this is, any dementia docs here will know this is a pretty typical kind of case. And this is because of the model that's not set up to prevent these kinds of consequences. A guy named Wagner back in the 80s came up with this chronic care model as a conceptual framework. And if you look at the different elements in this framework, a care team that includes non-physicians, community linkages to the resources you need, decision support, proactive follow-up, a prevention mindset and an approach, not a reaction to escalating problems approach, which is what classically happens in fee-for-service care. But as I said, none of these are compensated under fee-for-service care, so no surprise, this is not the model that could just go into evidence. So we wanted to generate some evidence to support this kind of model. There were a group of us working in California at the time on the advocacy groups were actually working with the state on some guidelines and convened some stakeholder groups. We went to these groups, a group of us from UCLA. We met with some folks from around the state. And the California Healthcare Foundation came out with an RFA for elders in managed care. And programs and interventions to do that. And so for those of you junior and you're wondering about that linear approach, sometimes there's opportunities because we showed up at those meetings, we spoke to some stakeholders from San Diego, an opportunity for funding came along, we'd been doing work in the area, and we put this group together because we agreed we all had a common goal of wanting to test a redesign of care delivery for dementia. And in this model, we built on the concepts of the chronic care model. There'd be a care manager who's primarily a social worker, and there's a panel of patients identified up front before. It's not like you're referred into this because a crisis happened. Let's find all the people diagnosed with dementia in our health system. We'll offer them and their caregivers this program. They're going to have a central social worker as their care manager. They're going to have a home visit from that care manager who's going to do a comprehensive assessment. And we had pre-planned with all our stakeholder groups the coordination around what kinds of problems could be triggered from the assessment and what would the resources be, what were the menu of resources the care manager could trigger and generate in collaboration with the patient and caregiver. Because it turns out if you're patient caregiver dyad and 16 of problems pop up, you can't work on them all at once. You got to prioritize them, right? So there was a lot of collaborative with all the partners here. There was communication back to the primary care doctor about here's what's going on, but we're not expecting you to take on this workload. It's a wraparound of primary care. And we had formal arrangements with community agencies that had services in the community. And that was somebody raised earlier about what do you do when there aren't? And in this case, we knew that there were organizations that could help connect people to respite care services or provide some, as well as I had other training programs, the local Alzheimer's Association, and they were frustrated because they felt like they were getting people only because they heard about it through their neighbor, not because they heard about it from their primary care doctor or the health system. Proactive follow-up. So it wasn't like, okay, we've assessed you, here's some things, call us when there's a problem. They repeatedly followed up. That was part of their job. And we used EMR. We used a software system that was through a grant from the state of California on technology advancements. This was way back, right? Some years ago. to make this a more efficient, because we figured if it was all very inefficient and paper, it just wasn't going to be something that was sustainable. We needed our care managers to be able to follow 50 to 75 dyads. And then we had regular ongoing meetings and self-management tools. And so here's the flow. This is after we spent probably 9-10 months figuring out the care goals that 3 organizations all in San Diego all agreed to, as well as our community agencies. The resource list and what the menus are for who would be referred for what. The problem list, which is there could be up to 23 problem areas that the assessment identified, the EMR builds, the staff hiring and the training. Because for a social worker at the time, the social workers said, that's in the organizations that even had social workers that geriatrics could call. They said, we get called about a crisis and we do maybe 1 follow-up. But it's all a reactive model. We're not doing anything in a different way. And I will say one of the social workers at the end of the trial said, I don't want to go back to the old way of doing social work after working in this model. So they would, there was a panel, there was proactive outreach to people on the panel. It didn't, for those who consented, yes, I want to enroll, they didn't, I mean, they were enrolled separately, I should say, because it was a trial. But once they were enrolled and randomized to the intervention arm, then the care managers would reach out, offer an initial home assessment, and then they would work to collaboratively prioritize what was triggered from it. Some people had few needs and some had a lot of needs. Okay, so it was tailored to the level of need of the individuals. They shared the care plan with the community partners because we'd already coordinated how they were going to handle different things. So there wasn't a lot of duplication or where do I go? And then they would reach out. And then there was ongoing follow-up by the care managers using this system that let them track their tasks. So they didn't have to like go look up one at a time. And they were formally patient caregivers reassessed at least every 6 months, but obviously they had more frequent calls if the needs were higher. Okay. So this is how this model with the purple circles looks afterwards. The idea is there's now a strong connection. First off, we've helped activate the caregivers so they understand when to call or how to manage certain kinds of problems. They know who to call if they have an issue. They're connected to the community agencies because the community agencies call them. If a problem is triggered, they don't have to wait and look for a piece of paper you'd lose. Within the healthcare system, there were protocols for when to involve other healthcare providers, and there was IT and decision support that helped that. Now, it's a busy slide, but the point I want to make here about implementation is, and for any of you interested in intervention work, I highly recommend you think about driver diagrams and causal models, because if you can't convince yourself that what you're proposing in this model is likely to lead to some kind of change that's likely to lead to some kind of an outcome, you can't convince anybody else, including people who you're seeking funding from. But it's a really important exercise. It's just vital for this kind of work. And I think of the secondary, and so here we have secondary drivers, and you could read through some of the examples which lead to a primary driver and then a proposal of an outcome. The secondary drivers I think of as key implementation ingredients. And so you want to be sure you're measuring those things along the way. You may have this great plan and you've trained everybody. I've got a great quote in the next slide or a few slides down about how the best laid plans can always go off in other directions because that's what's human to do. So when you're doing this kind of a study, you want to not only measure these things along the way, but you want to find out if things go amiss or you're not getting enough care plans done, or why aren't there 100% home assessments done, right? Like you're measuring the ingredients that the intervention is executing, and you want to then go back and ask why. You want to talk to the people involved and then try to see what you can do to either smooth out an obstacle, or maybe the people had a great idea and you want to actually adjust the design to include that. Both things can happen. And this is the quote. So the people involved in executing your study, not the evaluation people, but I mean the social worker, the people involved on the care teams, they're not passive recipients of innovations. They seek innovations, experiment with them, evaluate them, find or fail to find meaning in them, develop feelings, positive or negative, about them. Any of you, and wherever you're working, you probably know what this feeling is like, right? You worry about them, challenge them, complain about them, work around them, gain experience with them, modify them to fit particular tasks, and try to improve or redesign them, often through dialogue with other users. So what you want to do as a researcher in intervention research is capture that, take in the positive feedback and make adjustments, and try to bring back on into the protocol the things that are not positive aspects, or not likely to benefit this. So this is just some more about what implementation science is, but it's really looking into the ingredient part, those secondary drivers. Okay, so under a re-engineered model, maybe this is so obvious, but think about how different it is. The patient and caregiver, the same man, was contacted by the care manager based on admin data. Things hadn't fallen apart yet. She or he did a home assessment and identified some significant problems: behavior, because of the wandering, and the resistance to the meds, the comorbid heart failure impacted by the dementia, caregiver depression. They then prioritized the problems and made a care plan. And that included connecting the caregiver to the community agency for support services, behavior management training, but also within the health system, taking the caregiver to a CHF clinic where they did caregiver education around how to detect when somebody is starting to, with weight gain or whatever, through heart failure. Caregiver was referred for depression management, and the care manager proactively followed the case and followed up to see what was going on. And so those outcomes are very different. No further heart failure, hospitalizations, behavior problems are gone, patient remains at home. But no, I've got one. Oh, sorry. Thank you. I've already got one, but I wasn't using it. Thank you. Caregiver depression resolves. And this is the optimal outcome that we would like to see from chronic care management. So we needed evidence. We had 3 partners in San Diego, 3 health systems, and 3 community agencies. We co-developed our care goals, assessments, workflows. We met regularly throughout the study, rotating at each of their sites. We had a dedicated partner at the community agency. I want to emphasize that. There was somebody who was already hired there, but they had special training in the program and how to interact, and they had access to the care plans of the patients. And then we also had caregiver representation on our steering group meetings. We did a pre-post experimental design, intervention versus usual care, with an 18-month follow-up. Cluster trial, we had a lot of discussion, but its clinic was the unit of randomization and among 18 clinics in the 3 organizations. Medicare enrollees, 408 dyads enrolled in intention to treat. And so the results were, here we have, I've aggregated the care goals into 4 clusters: assessment, treatment, education, and safety. Within each of these, there were like 3 to 6 individual items. The y-axis is the mean % of care goals met. So there's a couple of observations here. Pink is the intervention at 18 months, taking into account baseline, right? And then the green is the usual care, same thing. So there's 2 things. One is, if this was a drug, the pharma company would go to market tomorrow because the intervention is so much more higher quality of care as a result. The second is there's room for improvement still, and across all the groups. So And we also looked at patient outcomes. These were our secondary endpoints, patient and caregiver outcomes, and most of these were actually highly significant as well, including the caregiver confidence in their caregiving. And this was part of the intermediate step was we wanted the caregivers to have more self-efficacy about their role. It looks like we did, and the rating of their healthcare. Now, after the trial, it wasn't designed to be looking at caregiver education levels, but pretty much everyone here would be familiar with literature that there's inequity in life expectancy by educational attainment. These are graphs for men and women of life expectancy at age 25 in years. And the 4 bars are going from less than a high school education to college graduate. And so there's a clear gradient, right? And you can, there's a lot of literature postulating what the pathway is between educational attainment and health outcomes. So we likewise found a gradient by caregiver educational attainment in the percent of the care goals that were met. And I'm showing you one. This was true for all 4. There were 4 categories, right? Assessment, treatment, education, and safety. And so caregivers with more education were at a higher level than those with less than a high school education. But when we compared the intervention and usual care groups, so we took there's a post hoc analysis and we divided the caregivers by level of education. And we saw that either the gradient went away and there was even across the board, that's the blue, or even a reverse relationship. So everybody improved. Everybody's boat floated for the intervention compared to usual care. And in some cases, there was an even bigger boost if you had lower educational attainment. And if you think about the content of this intervention was designed to look for need and address based on need in terms of the extent of the intervention. So it had the flexibility to both raise the level of care for everybody, but also to potentially, and it looked like it did, redress educational disparities. So now back to the 25-year journey. We finished this trial, I think in like 2002 or 3. I won't give you the backstory about the publication, but we eventually published in 2006 in Annals of Internal Medicine with a lovely editorial that said the usual fee-for-service approach just works awfully for dementia care. People need medical care that is coordinated among multiple team members and integrated with social and community-based resources, and Medicare should pay for team-based care management services because this is clearly going to improve quality of care. This is 2006. And in 2013, there was a Cochrane review, and there were 13 trials by then. So I think in 2006 that we and one other group both published the first trials. There were 11 more trials and 9,600 participants. We're still not paying for this kind of care. And in 2021, the National Academy of Medicine put together a stakeholder group that said, it's time for Medicare to pay for team-based care. They looked at all this literature, right? And I will say that this is where there was a lot of hard work and by the advocacy community. The National Action Plan for Alzheimer's Disease, or NAPA, had been pushed through, I think about 10 years earlier. But in the years up to 2021, they started really pushing on the message that you can't just look for a cure. We have lots of people with dementia now, and we need to have better care delivery. And there's a lot of evidence about what can produce better outcomes. Let's push really hard on this. And those advocates did. So what does it take to get financing changes? You need that research. You need the research. You have to get advocacy involved that pushes the block up the hill. And sometimes you hope before you finish your career, there's some changes. So there was some baby steps in about 2020, again, as from the advocacy push, where they at least got CMS to add some codes that were like fee for service on top of they were like to pay for team members' effort, but small amounts, and it wasn't linked to outcome. And it was still kind of fee for service. It's really hard. There have been administrations going back to the Obama administration trying to talk about moving to value-based payment. And that means basically, we're going to pay you a lump of money to produce better outcomes, but you've got to show you produce the better outcomes. And you have to believe you've got the tools and the necessary ingredients to actually put a care program together that will produce better outcomes. And so the health systems need the data and the evidence that you all are generating as well. And I do believe that this can advance health equity. And again, if you just think about I went through a kind of a painful description of the ingredients of this. And the reason is that to put that together, you can't do it on fee for service. And I've been a chair now for long enough, and I work with hospital and leadership and finance. If I go to them and I say, it's going to cost you this to put this program in place, but boy, it's going to produce better outcomes, they'll say, next, like we can't do that and sustain in our mission. So along about 2024, something big happened. And again, I would credit the advocacy community that just kept on pushing in Washington around this. And CMS said, we're putting up this new guide model for payment for under traditional Medicare for health systems or organizations that provide the following services. And I'm going to skip this. You have to have a care team, including a care navigator. That's a care manager. That's basically it. They were allowing for different phenotypes. We really strongly believe in a social worker. And then these are the ingredients that you have to have if you're going to be a recipient of guide funds from CMS. You have to do a comprehensive initial assessment. You have to have a care plan. You have to have somebody to call 24/7, ongoing monitoring and support, care coordination, referral and coordination of services and supports, medication management, caregiver education and support, and respite care services. Okay? And this is part of the ongoing management and support, which says that care navigator has to go back in and follow up on things and make sure that all these connections are being made to get the services to the patients. And here's the really potentially impactful part of it. The per patient per month monthly payments are enough to make a business case to health systems to say, this looks like something where we could actually put in place the program and it would pay for the services that are needed. It's not going to make anybody, not going to get some fantastic profit of any kind, but it's enough when you multiply this by the number of your patients in traditional Medicare at your health system. And when you think about the costs of their care, this is enough payment on a per month basis. It's been put in place for 7 years. And look, they've also got a performance-based adjustment. So they're monitoring performance. They're looking at cost and use of services. And you have to certify that you're actually implementing the program. But if there's evidence that these kinds of outcomes are improved, you actually get a bump in your payment. And there's a health equity adjustment that has to do with the area deprivation index, low income status, and some other things, which also gets a bump in the per patient per month payment. So a 25-year journey, I almost like, when I first saw this announcement, I just literally couldn't believe it. And I'm excited to say that at Sinai, we're one of there's probably 100 programs around the country that are participating in this, or will be starting up in 2025. It's a fantastic opportunity. Nothing happens without lots of partnerships. These are, again, my takeaways. I did want to close with follow your bliss and don't be afraid, and doors will open where you didn't know they were going to be. The group of you who don't know who Joseph Collins is, Google him afterwards. For my generation who remembers Bill Moyer interviewing him on the Power of Myth programs years ago, this really had a big impact on me. And I really think it's excellent advice, and I would share that with you. So thank you very much.
Very inspiring and also daunting in some ways, but at the end, ultimately very gratifying. So questions, please, Dr. Adams.
Just to say, I love it takes a coordinated village. I'll remember that. That's really terrific. Thank you very much. And then one quick question. This goggles, they've entered into the picture, found out. Do you have any comment one way or the other? And I know it's a big question, but whether they're at the end of the day going to end up being on the right side of things?
I don't know enough to know. I think it's hopefully whatever different initiatives are coming out, they're going to be done in a rigorous way. I think the other big part of dementia care right now is this whole thing about early diagnosis and easy diagnosis and the plasma biomarkers and how are people going to use them. And then, of course, there are some treatments out there that we hope will lead to better ones. But I think in principle, it's good that there's another funder out there looking to help advance things. The nuts and bolts of what they're doing, I don't know. Did you?
Oh, thank you for a very inspiring talk. Do you know if the guide model will apply to other neurologic disorders like stroke, or do we need to do the entire work to show the benefit?
That is a really important question. The Alzheimer's group, I can't overestimate how much clout and many years they have done to push to get guide in place. So far, it's just it's not a demonstration program. It's a policy program for 7 years. That's what they've said it'll be for 7 years. But I think it's the opening in the door to try to make that advocacy. So the Heart Association, the Stroke Association, whatever, they ought to be out there saying, well, if we're doing this for dementia care, we've got models in some other conditions, and we think that this could be expanded to that. So that would be the hope. Yeah.
Yeah, I want to kind of riff off of that because, chronic care management is something that is underutilized in neurology. And we have a clinical trial that's implementing chronic care management. And it does work. It is proactive. It is preventing a lot of delays between different blood pressure management epochs in time, and hopefully something like what you've accomplished would be, maybe an amalgamation of chronic care management and the guide model or principal care management, which we were not able to use because it really didn't include what we needed to. But this is really exciting.
Yeah, and again, I can't take credit for anything except working on the generating the evidence and of course partnering at points. But this was really, this was a lot of folks doing this. The PCM is the problem is it's too little money and it's not linked to outcomes. So it just was a sprinkling. You need a bigger change in payment policy.
So I was just going to read this and then just say we should take a picture along with Dr. Sharif. So Dr. Sharif is one of our board members, along with Dr. Ojwela, who's there, but Dr. Ojwela has already made a cameo. So do you mind coming here? If you don't mind, then we can have Barbara in the middle, if that's okay. Thank you so much. And just to say, it reads, for testing the effects of the chronic care model, based intervention amongst underserved stroke patients receiving care within the public healthcare system. Again, recognizing that Barbara has done so much more than that, and as you can see, but just honored to have her as one of our inaugural SEQUINS Hall of Famers. So thank you.